To share my favorite topic about CAH, and I will talk about the diagnosing and managing congenital adrenal hyperplasia without the full toolbox strategies for low middle income country. So CAH is or congenital adrenal hyperplasia is a group of genetic disorder affecting cortisol biosynthesis. And most commonly due to 21-hydroxylase deficiency due to CYP21A2 gene mutation. And the classical form incidence is 1 in 14 to 18,000. This CAH can potentially life-threatening due to the adrenal crisis, and the early diagnosis and management are critical to prevent morbidity and mortality, but resources limitation in low and middle income countries pose significant challenges. And here we actually see that there is a several type of CAH, but here we will discuss more about the 21-hydroxylase deficiency as the most common cause of CAH. So 21-hydroxylase deficiency is more than 90% of cases. So I will start with the pathophysiology. So this is just for reminder for us. So the adrenal cortex take part in steroidogenesis, producing glucocorticoid, mineralocorticoid, and also androgen. And in 21-hydroxylase deficiency, a mutation in CYP21A2 gene lead to impair of the activity of 21-hydroxylase enzyme, which is crucial for two key steps. First is the conversion of progesterone to 11-deoxycorticosterone, and that need for the conversion of 17-hydroxyprogesterone to 11-deoxycortisol that need for cortisol synthesis, and the conversion of 17-hydroxyprogesterone to 11-deoxycortisol that needed for cortisol synthesis, and the progesterone to 11-deoxycortisone that needed for aldosterone synthesis. And then what happened in 21-hydroxylase? So the cortisol level and the aldosterone level is decreased. And because of the cortisol deficiency, the pituitary gland secrete more ACTH or adrenocorticotropic hormone to stimulate the adrenal glands. And the overstimulation causes an accumulation of a steroid precursor and above the block here, especially 17-OHP. And this one is the parameter for newborn screening and also for the diagnosis and monitoring. And the excess of the precursor shunted into the androgen pathway and leading to increase in androgen like androstenedione and also testosterone. So the most important process here is about mineral corticoid, glucocorticoid, and androgen, or salt, sugar, and sex. And here it's like an graphical abstract show that when we have a 21-hydroxylase deficiency, there is a lack of aldosterone, and it makes the hyponatremia, hyperkalemia, hypotension, and weight loss. And about the cortisol, lack of the cortisol, it can cause the hypoglycemia, hypotension, weight loss, and also dehydration. And here, because we have more 17-OHP, and it will increasing the androstenedione and also testosterone and dihydrotestosterone. And it will relate it with the clinical situation such as precocious puberty, increased height velocity, impaired final height. There is a acne or hirsutism and menstrual disturbance. Basically, the type of CAH 21-hydroxylase deficiency, we divide it into the classic form and also non-classic form. For classic form, there is two types, salt wasting form and also simple virilizing form. In simple virilizing form, we still have a residual enzymatic activity of 1 to 5%. And the non-classic form is milder form. Maybe we do not have any possibility to discuss a lot about the non-classic, but we have non-classic form that have residual enzymatic activity of 30 to 50%. So this is the clinical manifestation of simple virilizing and salt wasting. For the classical form, for the most common type is salt wasting. So 75% of CAH is salt wasting type. And this one have the symptom of salt losing like hyponatremia, hyperkalemia, dehydration. Also, they will have a failure to thrive. And also they will have the similar symptom also with simple virilizing. If the baby with in the female or 46XX, they will have a genital ambiguity. And the other, they will have a hyperpigmentation, precocious puberty, and short stature. And for the non-classic form, we will see this form usually in the later life, like hyperandrogenism, menstrual disturbance, hirsutism, acne, or in the male, sometimes it's asymptomatic. So the diagnosis, ideally, we diagnose CAH with a newborn screening. But not every country have a CAH newborn screening, including our country in Indonesia. We just recently started this year for a CAH newborn screening. And if we cannot do newborn screening, then we will have a maybe late identified patient. So we have clinical features and hormonal testing. Usually we will test for 17-OHP, androstenedione. If there is a possibility, we can check renin. And usually in low middle income country, such as in my country, we don't have renin. So we only check the electrolyte. And also we can do ACTH stimulation test when we doubt about the diagnosis. And if possible, we can do the molecular genetic analysis for CYP21A2 gene mutation. So we have some diagnostic challenges in low middle income country. First is about the limited newborn screening. So most low middle income country like national newborn screening program for CAH, unlike high income country. And the second is about the laboratory constraint. So access to advanced diagnosis tool, for example, mass spectrometry, genetic testing is also often unavailable. So in Indonesia, for example, we have the tandem mass around in 2020. So before that, we sent the 17-OHP to Singapore or to United States. So it's very expensive at that moment. And the delay presentation, sometimes it's also related with the lack of awareness, but also the cultural belief and limited healthcare access to the referral hospital. And the diagnostic approach, yeah, we have also difficulty sometimes to reach the basic biochemical tests, such as 17-hydroxyprogesterone. And this is one of the example in our center. We found a late diagnosis patient, so they have a phenotypic variation of 46XX late identified CAH, and most of them, they have a hyperpigmentation. Also, they have some of them have a short stature in adult, and there is a rapid growth and precocious puberty and other symptom of the late diagnosis. And we also have still untreated patient, and some of them even choose male gender and still without treatment. This is particularly for the simple virilizing. And in low middle income country, how we diagnose, we do diagnostic approach to newborn suspected with 21-hydroxylase deficiency. Maybe we can start with the clinical presentation. This is particularly for girl with CAH. So they will show the ambiguous genitalia, and this one is medical and social emergency. For low middle income country, usually the gender identity is very important. So when we, for example, in our country, we cannot have the for the baby, we cannot have the government insurance when we cannot make a decision what is the gender of the baby. So for the clinical presentation, usually we will see that the salt-losing form with the vomiting, dehydration, failure to thrive, and usually start after 2 weeks. This one, this baby look very marasmic. Yeah, they have the muscle wasting, baggy pant, and also the looks very thin and very hyperpigmentation. And we have to check the family history, for example, the consanguinity, because this is an autosomal recessive. Also, the history of previous child with frequent vomiting, genitalia ambiguity, and hyperpigmentation. A family history of early neonatal death, because this may be the salt-losing condition. And physical examination in female with CAH, we will see the clitoral enlargement and also displacement of the vaginal opening toward into urethra, posterior fusion of the labia. This is a scrotalization of the skin labia, and also hyperpigmentation and absence of gonad in the scrotal fold or labia. So we cannot palpate the testicle. And we can see the Prader stage for examining the virilization in the genitalia. We have a Prader 1, 2, 3, 4, 5, and we can see the variation of the virilization in the baby. And for the laboratory investigation, I think in our country, the most easier one is to check the serum of the sodium, potassium, and also blood glucose. 17-OHP, if we have the opportunity to check, and then androstenedione or testosterone and renin. And also, if there is a genitalia ambiguity, we can check also the karyotype. And if possible, we can do CYP21A2 gene mutation. But I think if we don't have androstenedione, testosterone, or renin, we can check hopefully we have the 17-OHP to establish the diagnosis. And how about the simple virilizing form of CAH later in childhood? Usually the girl with the classic CAH, they have a virilization, premature puberty, tall stature, and increased linear growth rate. And boys with classic CAH also have the same condition, and also they have increasing fennel size, usually at any age after 1 or 2 years. And we can check the relevant previous medical history, such as growth history, the tempo of development of puberty or other sign of skin puberty. And we also can ask them, does the child become sicker than peers during long-standing high fever? And has he or he ever been found to be hypertensive? We have to aware about the 11 beta hydroxylase deficiency. And from the physical examination, this is, I think, very, very important because this is a cheap and easier tool. We have to check the weight and height, and also we put in the growth chart and check the growth velocity. And hyperpigmentation, we can check the blood pressure and all sign of androgen action, like skin puberty, muscle and fennel development, also the voice level. And investigation at the first and subsequent visit, we need to check sodium and potassium level, 17-OHP, bone age, and also the abdominal ultrasound to exclude adrenal tumor if we find in the late identified patient. We have to exclude the adrenal tumor. And according to the current insight in pathophysiology diagnosis and management review, this is the management of CAH. We have to have the hormonal treatment for classic CAH, regular monitoring, management of adrenal emergency, urogenital surgery, psychological assessment, and intervention. So I will discuss about the first three point of the management of CAH. So according to the Endocrine Society Clinical Practice Guideline in 2018, they published about the maintenance therapy of CAH. So for the growing patient with CAH, so this is for baby and children with CAH, they usually suggest the hydrocortisone tablet, 10 to 15 milligram per meter square. Also the fludrocortisone tablets, 0.05 to 0.2 milligram per day. And also sodium chloride supplement, 1 to 2 gram per day in infancy. And we can divide it into several feeding. And in the fully grown patient, if there is no hydrocortisone, we can use a prednisone, methylprednisolone, dexamethasone. And for the dose of hydrocortisone, usually they suggested 15 to 25 in 2 to 3 daily doses. But we can use other because there is many question of the participant about the when we can switch from hydrocortisone. So the guideline recommend after they stop grow. So usually for my clinical setting, if they are the bone age is already close and they are already nearly adult and they have a difficulty with the compliance or the price of medication if they don't have the insurance, so we suggest the prednisone or or prednisolone. And how about the treatment monitoring? So monitoring glucocorticoid, usually we can see actually from the history. So we see the symptom of adrenal insufficiency such as fatigue, headache, nausea, abdominal pain, or postural dizziness, frequency, stress dosing. So we have to, the goals is no sign of adrenal insufficiency. So we have to give them also the adrenal crisis prevention education. So usually we will give the patient education about 6-day rules. So how to increase the dose, when to increase the dose, and also we usually give an emergency card. And we can see the history of menstrual cycle. If they have a good compliance, usually will have also the regular menstrual cycle. We can see also the sexual health, libido, and erection in male. And for physical examination, the monitoring glucocorticoid replacement, we can see the height. So we hope that their linear growth within the target range. And so this is a very important in low middle income country about to check the growth chart, particularly the height velocity. Also, we have to check the Tanner stage of the patient and also the blood pressure, BMI, and we have to check the sign of over-treatment or under-treatment. So if there is a over-treatment, usually they will have a Cushingoid feature, striae, and also other sign of hypercortisolism. And imaging is also important for monitoring, particularly if we don't have the biochemical monitoring. So bone age is very helpful. If there is a advanced bone age, probably we need to check the compliance, the dose of the medication. So there is also a suggestion about the scrotal ultrasound every 2 to 5 years. And if there is a unexplained hyperandrogenism, maybe We also check the ovarian ultrasound. And other, like semen analysis, if there is a TART or testicular adrenal rest tumor, also the genetic counseling and assessment. And the other important thing is about the management of stress dose for adrenal insufficiency. So at home, if there is a major illness or high-grade fever or more than 39 Celsius degree, we will suggest 3 times the usual dose of hydrocortisone and divide it into 4 doses given every 6 hours. And drink regularly, increase fluid intake for concentrated urine, and also eat simplex or complex carbohydrate. If there is a gastroenteritis with the diarrhea or vomiting with or without fever, we also suggest 3 times the usual dose of hydrocortisone. And also, if there is a gastroenteritis with a vomiting or diarrhea, consider early parenteral hydrocortisone. And if unable to tolerate fluid, we can also give a glucocorticoid injection and also go to the hospital. And here, one of the important for the stress dose management about the emergency card. This is our example in Indonesia. We have the emergency card in Indonesian language. And if possible, actually we give them hydrocortisone injection. But sometimes it's difficult to bring hydrocortisone back. So if there is no hydrocortisone injection in the area, we can also suggest them to have another glucocorticoid, such as dexamethasone or prednisolone. And for adrenal insufficiency for minor illness or low-grade fever or more than 38 Celsius degree, usually we suggest 2 to 3 times the usual dose of hydrocortisone. So divide it into 3 to 4 doses and drink regularly and increase fluid intake also. However, sometimes the patient also don't have a temperature at home. So for us, usually we will give them recommendation 3 times doses after 38 Celsius degree. Okay, this is the example of the stress dose education in local language in Indonesia. So we have this kind of booklet and we give them education about how to do when they have they sick. And for the major surgery, we also suggest the hydrocortisone intravenous bolus, 50 to 100 milligram, or in children, we can also calculate 50 to 100 milligram per meter square, and followed by continuous intravenous hydrocortisone infusion over 24 hours. And for short surgery, we also give hydrocortisone intramuscular or intravenous bolus just before anesthesia. Or if they don't have hydrocortisone, we can give triple the usual dose morning before oral intake is held. Also for the acute emergency, we need to add the rapid infusion of intravenous fluid with the sodium chloride. And also the hydrocortisone bolus followed by continuous intravenous infusion. For hypoglycemia, we need to give them also dextrose, and we can give also in the infusion. And this is in our clinical setting. This one of our case about 2-month-old boy referred to tertiary hospital due to frequent vomiting, failure to thrive, and ambiguous genitalia. And we can see here that there is a marasmic feature, dehydrated, and no palpable testicle. And for the laboratory, there is a hyponatremia, hyperkalemia, and a little bit low of blood glucose level. And in pedigree, this is the only one child in the family. There is no consanguinity. And in the beginning, actually, they are discussing whether this one is the clitoromegaly with partial label fusion, or this is under sensus testis with a bilateral hypospadia. And then we also find, finally, we also check the karyotype, 46XX and 17OHP is very high. The karyotype in our country is very important because sometimes when they need to change in the court for the birth certificate, we need some proof tools like karyotyping. And the problem in this patient is let identified the male name and birth certificate that must be changed in the court, and how to deal with neighbor and relative, how to comply with long life need medication, and yeah, this one is also need the genetic counseling for the next offspring. This is our case. The other case, this is case 2. The 2-month-old boy come to hospital due to vomiting, dehydration, failure to thrive. There is a hyperpigmentation, hyponatremia, and hyperkalemia. In this pedigree, we can see that the history of 3 brothers who died due to vomiting, dehydration, and hyperpigmentation. So we have to aware if there is a history of the previous sibling with the vomiting, dehydration, and hyperpigmentation. Just remember that the male, there is no genitalia ambiguity for CAH. And the third is about the late identified male. So there is 1 year, 10-month-old boy came to our hospital due to the taller than his peer, and he got bullying in the school. From the physical examination, we saw that the boy with the tall stature, because the height for age is more than 2 standard deviation. There is a hyperpigmentation, acne, pubic hair, and testicle is 8 milliliter without a palpable testicular nodule. However, when we check the bone age is accordant with male age 16 years or accelerated skeletal development, and we found the testicular adrenal rest tumor in this patient. How about some of the participant also asked about how to check the other CAH type. We just presented in the SPSA meeting this year. This is the adrenal insufficiency with low 17-OHP, lesson learned from a developing country. We found that there is a patient, actually it come with the recurrent hypoglycemia and hyperpigmentation, recurrent vomiting. And in the pedigree, we see that the sibling is already died due to the same condition. And we check the genitalia, actually it's look like female, and there is no clitoromegaly, no palpable testicle. And it's not the usual features of CAH, like 21 hydroxylase deficiency, because there is no clitoromegaly, but it's look like female. So when we check the 17 OHP level was low, and the natrium level was low, and the glucose also low, but the potassium is high. So this patient looked like adrenal insufficiency condition, but not 21 hydroxylase deficiency. So we check the karyotype 46XY. And finally, we send this DNA to Radboud University Medical Center in Nijmegen, the Netherlands. And we find that this patient actually is the star mutation. So this is the first reported cases of star mutation in Indonesia. And we also have another patient that look like adrenal insufficiency. In the beginning, I checked this. I thought that this is maybe CAH, but we checked that 17 OHP level also low, the cortisol level low, and natrium also low. And finally, we checked the genetic mutation, and we found that actually this one is the NROB1, a gene mutation, as the causative of for X-linked recessive congenital adrenal hypoplasia. So our conclusion, we have to, if there is a specific features leading to with adrenal insufficiency, but not specific like CAH, we have to think about other cause of CAH. So our take-home message today: CAH is a spectrum of the adrenal deficiency with variable clinical severity, and early diagnosis via newborn screening and hormonal testing is crucial. And even without full diagnostic, CAH can be recognized and managed effectively in low-middle income country through clinical skill, education, and also collaboration. And I would like to acknowledge our team in Center for Biomedical Research in Faculty of Medicine, Diponegoro University, our collaborator at both University Medical Center and Erasmus Medical Center, and also our group, Indonesian Pediatric Endocrinology Working Group. And thank you for GPED and also CLAN for supporting us with many program and also helping us in the beginning of our management and giving donation for the treatment. Thank you so much.
So thank you, Dr. Agostini, for this informative and powerful presentation. We already received lots of questions and we'll discuss that in the Q&A session. So I'm now pleased to introduce our next speaker, Dr. Paula Duran, who will be presenting on partnering with families, the impact of parent organization in CAH care. So Dr. Paula Duran is graduated from the University of Bogota, Colombia, where she did a medical degree, and following that, she pursued a specialization in pediatrics at the University of Miami, while after that training in pediatric endocrinology at the University of Miami and Bern, Switzerland. She now currently serves as the Chief of Pediatric Endocrinology at the Fundación Cardio Infantil in Bogota, Colombia. She's also the director of the Foundation CENDO and a pediatric endocrinologist at Endosia SAS. So in addition to her clinical role, she's a dedicated educator, serving as professor of pediatric endocrinology at the University of Rosario, University del Bosque, and La Sabana in Bogota, Colombia. She's also part of several professional organizations. She's part of CLAN and MTA's For Kids in the Americas region. She's part of GPED, part of the Colombian Association and Latin American Pediatric Association. So I'm happy that we can hear Paula Duran about talking about that specific topic, and the floor is yours.
Hello, thank you everyone for being here with us today. I'm going to try to share my screen. Can you see my screen?
Yeah, we can see that.
Okay. Okay, well, thank you, Dr. Agostini, for the wonderful review. And now I am going to talk about partnering with families and the impact of the parent organization in CAH care. So as we already have outlined, there are many clinical challenges in treating congenital adrenal hyperplasia and in the living with congenital adrenal hyperplasia. I am going to outline some of the main clinical challenges regarding the parental focus and the community focus. So The research often focuses on health complications, emergency management, and consequences of excess androgen exposure. And there is also a lack of consensus on the management approaches, which is a challenge for clinicians and patients. The patients report difficulties remembering the medication and also balancing the frequent doses with the busy lifestyles. And they also have to be responsible for adapting the medication for the sick days and also to prevent adrenal crisis. And on top of that, there is insufficient education about adrenal crisis management to the families and to the caregivers. So we have always been focused on the research about clinical consequences for patients, but there is a very wide experience of the condition from the perspective of the family members and the caregivers that has been neglected in the research. And on top of that, the studies have highlighted the challenges with information and support provided to parents after the diagnosis and preparing them for managing those adrenal crises and taking care of the child at home. So why is it so important to focus on the parents? The parents and the caregivers are the mediators between the child and the professionals, and they play a crucial role in how the children adjust and manage the illness. They also underpin the well-being of the family unit. And there is a critical nature of the treatment regimen that if we understand how the family lives that and how is the illness experience for them, we will be much more able to support them and to give them the information they need. It is also very important to focus on the first 5 years after diagnosis, which have been found to be the most stressing for the family and the caregivers. The challenges have been divided into different periods by the interviews and the papers that have been published. During the period diagnosis, the parents and the family, they under stress, the stress, it's a big stress about the lack of awareness among the healthcare professional. Sometimes they have to fight for a diagnosis and try to find someone who really understands and make the diagnosis. It is not general practitioners and other health providers usually do not have enough knowledge about and may miss the diagnosis. And also another challenge is that most of the time the diagnosis is made at the time of an adrenal crisis when the children has already deteriorated and it is much more stressful for the family. It has been shown that when the diagnosis is made by the newborn screening, this reduces the stress because it has time to prevent and the family doesn't have to go on the stress of looking at the child, at the children deteriorate and get to the adrenal crisis. And that's difference between the countries. For example, in the papers review, the UK had no children diagnosed by newborn screening, but in the Netherlands, 70% of the children were diagnosed by newborn screening, and the experience was very different. And even though after the diagnosis, they struggle to access to specialists with appropriate knowledge. And most of these papers are in Europe, where they probably have more resources than us in the low middle income countries. The second period studied is the treating and managing and the period of treating and managing the condition. And the parents report burden, anxiety, and disruption because it is a very intensive treatment regimen. They have difficulty with the correct medication, and it is very important to give the correct dosing. And most of the countries, low and middle income countries, we have difficulties not only in preparation, but also in getting the medication. And we know that in many of our countries, it is difficult to get the medication. And also is a medication that he has to be given frequent in time. So they say there is a constant management of all that, and there is a latent anxiety. And so that also leads to a difficulty in delegating the care to other adults, to the school, or to other facilities to leave the children. And they feel responsible, the parents and the caregiver, to train the staff or the people that are going to take care of their child or of their son. And also when there are some medication errors, that has a big emotional impact and guilt on the families and the caregivers. So some parents even gave up work to manage the transition and to take care of the child. And on top of that, we know that there are frequent medical appointments, and some of those families have to travel very far and to get to the specialist. So that has a disruption to the family life, and that impacts not only the siblings, the family, but also the school life of the children. Also, all the families and the caregivers interviewed worry about the future. They expressed a big concern about the possible long-term effects of the condition and and also the long-term effect of giving the medication. Would they grow normal? Would they have a normal development and fertility? And that is a big worry. And also they worry about their child coping and taking the responsibility of their own care when they grow older, and if they will have surgery or had surgery. And there is a big concern about the transition from pediatric to adult health services. There has been research about that, and there is not one program that adapts to every area of the world. So everyone has to find the best way to do that. And it also has been shown that after the first 3 years of transition to pediatric from adult care, it is the period where the patients get most lost of follow-up. So that is an area where we need research, and it has to be taken care of. And also the parents did not want their child to grow up feeling different from their peers. So 98% of the surveys in all the papers responded that they worry about their child's future. Also, we all know that there are unmet support needs. There is a lack of access to psychological services, and also there is limited knowledge of the condition about many of the healthcare providers. So why it is so important, and what is the role of the support organizations and peer support? I'm going to talk to you about another paper. This one was made in the United States at the Johns Hopkins University by the Department of the Psychiatry, with 7 peer support programs operating in the healthcare and community settings. They conducted 43 semi-structured interviews with key informants. They did audio recordings, qualitative analysis, and used grounded theory methods. So they really found a big value of connecting with other families. Most of the people they interviewed, they reported as very important, even pivotal, and a source of support. The parents found it helpful to share experience and practical advice with other families. However, it is surprising that a minority of patients access this kind of contact. But there are many general benefits of peer support programs. When individuals connect and share experience, they also share knowledge of practical information, and they share the knowledge of managing a similar condition. They also get some psychological and informational support, and they learn between them to navigate the health system, which is also different in every country, and it's a key point to get under control the treatment. But also they foster a sense of belonging, which is also very important. It reduces social isolation. They report feeling less alone, feeling normal, being accepted, and we all know that is very important. They get that practical self-care knowledge, which is information that is very practical about the day-by-day living, and they only know about that because they live with that. And also they connect to resources like transportation, which is a very big issue in many countries to get to the medical appointments. And also, as I said, they navigate the health services, which is also a key point. And this is all complementary to professional care. It was found to have benefits for the family caregivers because it helped them anticipate life changes and to better understand their role. They gained confidence to ask questions and to advocate for the services that they can have for their loved ones. And also, of course, the engagement in peer support, it's fundamental. It's a coping mechanism for caregivers. And for the peer mentors, it also have benefit emotionally and socially. It gives them, and they talk about a sense of purpose and confidence in their own recovery, and helping others is something that feels like continued therapy and obviously gives them a sense of purpose. When we look at the parental involvement in interventions, there are two key mechanisms that have been shown to be very beneficial. First, there is an increased child active coping skills. They have a significant increase in social competence and information seeking. And so it decreases the child internalizing the problems. And the parents, it decreases the parent stress. It increases the parental confidence. It gives them a better knowledge of the illness, emotional support from other parents, and also that leads to improved parent-child relationship, which is very important. So this parental involvement helps support the generalization of skills in daily life, and it also facilitates their continued use beyond therapy. And it addresses the parent-related obstacles to treatment success. And this is it has been shown to be key for the adherence to the treatment and also to have a better quality of life and feel supported. Another point that it's very important about the support groups and have a family-centered care is the co-creation. Co-creation with family is critical, and it has a healthcare transformation. Because when you build solutions that work you need to build solutions that work for the family, and co-create with the family, ensure that they align with the family needs and realities. And also it builds trust, and so it gets to a better collaboration, and it improves the delivery of care. So we really co-create with the family is essential for the system's level change, and they must be involved in all policy change and decisions that affect their health care. So there is this powerful sentence, nothing about us without us. It is something very important to do those changes. So the families need to be involved from the beginning to the end, and they need to contribute as decision makers. And so it's important to have listening sessions to encourage more open conversation and more even power dynamic, and also use plain language so everyone can understand and can be involved and in the process of co-creation. And that will have implications for healthcare providers. We really need to improve awareness around adrenal crisis. We need to establish rapid referral pathway to experienced clinicians. We need to provide information and reassurance about diagnosis testing for newborns and the ongoing care. Also, from very early, address the parents' concern about delegating care and their child's future, maybe as early at 12 or 13 years old, start that transition so we can give the patient some autonomy in their treatment and start doing that from very early. And always have a multidisciplinary and holistic approach to meet the complex needs of those families and to optimize the services to consider the family needs. Now I'm going to talk to you about the experience in Colombia. For those of you who are not familiar with Colombia, it is a country with a population over 52 million. It is an upper middle income economy. It has a high Gini index, and it has a fairly high mortality rate. Also, I'm going to talk to you about the CAH and Mates for Kids movement, which is a coalition of like-minded organizations and individuals committed to collaborative action aimed at identifying, implementing, and monitoring practical solutions to improve access to essential medicine for the global CAH community. It was developed by CLAN, which is an Australian NGO, caring and living as neighbors. And the aim of this movement is to reduce the preventable mortality currently associated with CAH by 30% by 2030, in line with the WHO. So this community of practice, we have been collaborating since March 2023 with Fundación Siendo in Colombia, CLAN, Global Pediatric Endocrinology and Diabetes, also the Colombian Association for Pediatric Endocrinology, and one of the biggest children's hospital in Bogota, which is the capital of Colombia, La Fundación Cardioinfantil. So the first thing we did, the first step was in March 2023 when we applied a snapshot survey. It was designed by CLAN and adapted to Colombia to have the perception of the Colombian pediatric endocrinologists on the disadvantage, disability, morbidity, and mortality experienced by children living with CAH in Colombia. We had a good participation. We were 80 pediatric endocrinologists by that time, and we obtained 78 responses, which is 97.5% of the pediatric endocrinologists in 5 days. We obtained many answers, but I am going to highlight that the education, the research, and the medical knowledge had a very low score, and the support groups had a very low score. I mean, the perception of the pediatric endocrinologists on how important the support groups were, and also on the point I outlined, were very low. Then from June 2023 to July 2023, we did a GPED survey, which actually was done in Latin America to the Latin American Pediatric Endocrine Society, but I am going to only talk about the results in Colombia. And this survey was to understand the perception of the pediatric endocrinologists in the access to medication and newborn screen. So fludrocortisone was felt to be 100% available, but 75% of the pediendo thought it was available free of charge only to 33% of the patients. The same for oral hydrocortisone. And for the IV hydrocortisone, they felt it was 100% available, but only 60% of patients had it free of charge. And the newborn screening at that time was only felt to be available to 48% of the patients at a national level. So now we wanted to see what was the perception of the families, and there was no peer support groups in Colombia at that time for the families living with a CAH, and no community of families. So we decided to do the first club meeting in Colombia using the 5 pillars and knowledge to action of CLAN. For those of you who are not familiar with the 5 pillars of CLAN, the first one is to ensure affordable access to medication and equipment. The second one is education, research, and advocacy. The third one is optimal medical management. The fourth, encourage family support groups. And the fifth one is to reduce poverty and promote financial independence. So based on those 5 pillars, with the health need assessment, which is a survey that was developed by CLAN, but also adapted to Colombia. We did a pilot study with the 7 families to adapt it to Colombia. And then we got an ethics committee approval. And so we did the first Colombian club meeting. We had 111 assistants from 32 families that live with the CAH in Bogota and the surroundings, Bogota being the capital of Colombia. We transcribed the information to the RedCap platform, and we obtained some results. So what the family expressed is that even though in Colombia there is said to be a 99% health coverage, still 90% of the families use 1/4 of their income for treatment and hospitalization. There is a lack of education. Less than 50% received information regarding the condition from their doctor, and mostly received the information online. And there is a major difficulty, which is the access to quality healthcare and education. And those are the main things we need to work with the families. The other good thing is that during this club meeting, the community was developed, the first community of families living with the CAH in Colombia. And the community is functioning and it's growing. At the beginning, we had 32 families, and in 1 year, we are more than 60 families in this community. They have their own WhatsApp group, and they have now 159 followers in Instagram. And what they do is they're trying to expand coverage, educational events, and they share information, and of course, give support and all the things that we have outlined that is important to have in a support group or in a community. And they are supported and promoted by Ciendo Foundation. After we had the responses of the health need assessment, we used the check score, which is the Child Health Equity Checklist account that it was designed by CLAN as well. And it is meant to identify with some of the key questions that are in the health need assessment to identify the most vulnerable families. And so applying the check score, we have 7 families that were in very vulnerable condition. That's 21.8% of the 32 families that went to the club meeting. And the major concern of these 7 families, which had a telephone interview and we talked to the parents, it was transportation and food expenses. They could not get to the medical appointment because it was very difficult for them to pay for transportation. And when they go to the medical appointment, which is far away from the place they live, they have to stay the whole day without eating, or even nobody eating at home, so they can get to the medical appointments. And of course, also they fight to get a medical appointment. So with the Fundación Ciendo, we studied the subsidies we could give to these families, and we have been helping them for the whole year to get to the medical appointment and with the concerns. And we also have been doing a lot of education. So on 2025, what we wanted to do is to expand that to other areas of the country. So we went to a smaller city, which is Barranquilla, in the Atlantic coast of Colombia. And we did again the club meeting and the health need assessment. We had 65 assistants with 19 families coming from the surrounding area of Barranquilla and from Barranquilla. And what happened also in this club meeting, what was very powerful is that we had a listening session where we encouraged an open conversation, and we could listen and also answer questions to the families. And that was also possible because it was a little smaller meeting. So, but we listened to them, and we could also answer their questions, and they also got involved with the community of patients. What also happened this year is that the Colombian CAH community had a space at the National Pediatric Endocrinology Congress. They had a stand, so it was a great opportunity to interact with the doctors, to raise awareness of the community, and to emphasize on that important co-creation with them. So we have been working with that. And Angela Castro is one of the leaders of the community. She's now 18 years old, and she left us with this message. She said that before the community, she felt she was alone. She was the only person. She didn't know anybody else that had CAH, and she had never talked to anybody else that lived with a CAH. So she felt really alone, and she felt really bad. But it was absolutely transformational to her to meet other people that live with a CAH, other family, to share experience of the daily life of living with a CAH. and also to help other people that maybe has less access to education, because she lives in Bogota, and she has had education. It helped her grow as a person, and it really gave her a purpose, and it has been very fulfilling for her. So the key takeaways is that families with CAH face a significant burden, which is characterized by challenges during diagnosis, managing treatment, concerns about the future, and unmet needs for practical and emotional support. And the parents' organizations and support groups provide a pivotal support by connecting families, offering practical advice, and reducing social isolation. The research demonstrates that the parental involvement in interventions improves child active coping skills and reduces parenting stress, and that leads to a reduction in child internalizing problems. And there is a clear need for better practical and emotional support, including professionals and psychological services, and also this access to peer-to-peer support. So we as healthcare providers need to encourage that, and so that as many families participate in those communities and peer-to-peer support group to reduce the parental burden and to improve the child health outcomes. What would be the main future directions? So in further research, we should capture the experiences of a wider range of families, including those that are less engaged with a support organization. And we need to study which is the best way to do the transition of care from not only from parents to other adults, but also from pediatric to adult care, and also to the self-management by the maturing patient. That is very important. And we need studies to compare the effectiveness of these various peer support delivery approaches, and to understand which are the best ones so we can give this support to the families. And also do that co-creation, integrate the family to the changes we want to do, and let them have a decision making. And we really need to understand that to get them to the healthcare system and to design services to be more welcoming to the families. So thank you very much for listening and for being here. If you want more detailed information, well, you can get it in this QR about how we did the first club meeting. And of course, if you need any information, or if you want me to share any of the tools we use, I'll be more than welcome to share it with you. And this is my email where you can write to me. And finally, I want to say that for the first club meeting, we obtained a grant from the AdMade for Kids movement, and it was very helpful, not only in guidance on how to do things and with the tools that Clan and AdMade for Kids shared with us, but also with the resources that we got from the grant. So the round 6 is now open, and it is due by August 31st, and I encourage you to apply to that grant for the initiatives that you are preparing. Thank you very much.
Thank you very much for this impressive talk and all that you've built for your patients. So I'm quite sure all of the participants are eager to ask their questions. So we will begin our discussion sessions. So as a first questions for Dr. Agustini from Samaya Aftab, what would you say about that? We are observing very high fatality rates, 17 OHP level, especially in preterm and intrauterine growth retardation, making it really difficult. And we don't have urinary steroid profile. How will you address this issue?
Thank you very much, Celine, and thank you for Somaya for your question. So usually in the preterm and IUGR, we can repeat the measurement, because usually in the early life they will have a really increase of 17 OHP, and if we don't have urinary steroid profile, we can repeat the measurement of 17 OHP after 2 weeks. of age. So we can see that after getting older, usually the 17 OHP is more reliable to measure the steroid profile. So usually we will do that. And we can also check the 21 deoxycortisol if possible.
Perfect. Thank you very much. So the next questions would be for Dr. Duran. So I was wondering, what would be your advice to create a parent organization? Where to start? How would you initiate this in a department in a country where it has not been created yet? What you think would be the main challenges this organization would face, such as limited resources, lack of institutional support? What are your thoughts?
Okay, thank you for the question. So I think there is a methodology that has that worked very well in many countries, and it's the methodology clan has shared with us, and I think it works very well to do the club meeting. So you can get all the families together, and then you give them the health need assessment, and you understand their needs, and also you encourage that and you encourage them to do or to make the community and to do that organization. And yes, there are limited resources. We did get a lot of institutional support. So I think there are many organizations that help, and also not only CLAN, but also CAH International, CAH Cares Foundation. I mean, if you get that international support, then you also can get resources, and I think it is the best way to do it. And if you don't have a community of patients or an organization in your country, I really encourage you to do it, because it is very helpful, and the families have a much better quality of life. It really helps them, as I said, to navigate the health system, to support each other, and to get that education. And even in Colombia, what happened is that sometimes if they don't have the medication because they couldn't get it for that month, they share it between them, and then the next month when they get the medication, they give it back to the person that helped. And it also helps to put together the families that are more wealthy and the families that have more difficulties. And these are the persons that really understand the condition, and they are always willing to help the others. And I've found that very powerful.
Yeah, that was one of my next questions that we'll discuss later a bit further. So the next question for Dr. Agustini, that's two questions from Dr. Saddam Hussein from Pakistan. I have two patients born to non-consanguineous parents. One child is classical, the other one is simple virilizing. Which genetic mechanism explain this spectrum within the same gene locus? And linked to it is how you would provide genetic counseling to these parents in resource limited settings, and if you had any linked for free testing.
Okay, thank you for the question, Dr. Saddam Hussein from Pakistan. So this may be for the first question, why they have a different phenotype. It's possible because the compound heterozygosity within CYP21A2 gene mutation. So this means that each parent carries a different mutation in CYP21A2 gene. And the child maybe have inherit a different combination of those mutation. For example, one child inherit two severe mutation and it will result with a self-wasting form, and the other inherit one severe and one milder mutation, and maybe it will show with a simple virilizing form. And the other possibility is the epigenetic factor. Sometimes it makes that is a little bit different phenotype. And also in my experience in Indonesia, um, some of our patient that already have the genetic mutation analysis and show that this is according to that review. Actually, this patient, both of this girl have a Southwestern form. However, they survive until adult because they late identified and they did not show the Southwestern condition. So we have some of the patient because actually we divided or we make the difference between Southwestern and simple virilizing according to the residual enzymatic capacity, but maybe it's in the not in all patient will have the same condition. And the other thing, sometimes if we don't have the mutation analysis, for example, when one of the baby have the infection, for example, so they will have the salt with have the phenotype of Southwestern. So maybe they have a vomiting and hydration and etc. So at that moment they look like Southwestern form. So we have to aware about this also. And about the genetic counseling to this parent, for me, if sometimes we don't have the genetic analysis, except if we have a collaboration for the some studies. So, for example, in our center, we have a collaboration with Radboud University Medical Center in the Netherlands, and we have already have a MOU for several years to send the mutation analysis to them. So we can have some of our patient have a mutation analysis result, but the other no. So when we don't have the mutation, we give, if we assure that this is a 21 hydroxylase deficiency, so I will give them genetic counseling that the patient, the parent will be the carrier, and we give the possibility to have children with the CAH, but we don't give them the result of mutation if we don't have it. So I think free testing for CAH, I'm not sure for CAH, but for the SD, we have some place to send the DNA. But for CAH, I think I never know that. Maybe Solen or Paula, do you know where is the free testing available for CAH mutation?
We'll be working on that with GPED next year, so that it can be available.
Yeah. Okay.
So the next questions for Dr. Duran. So I was thinking about it. Would you think that kind of pairing a newly diagnosed kids with CAH to an older family who has already been through this whole process of the psychological consequences of the diagnosis, would you think that would be a good idea? Is it something that you've done in your country?
Yes, thank you for that question. That is very important. They worry so much about the future, and mostly the newly diagnosed families have the most stress. It has been shown that the first 5 years after the diagnosis, it is very stressful. They worry very much. And only by seeing somebody older that is doing well, that is achieving its dreams and goals in life, it is absolutely life-changing for them. And that is many of the testimonies that we get from the families, not only getting to know somebody else that lives with a CAH and talking about the day-to-day experiences, but also the younger children looking at the older children and how they can identify themselves and see that they can get through everything in a good way. So that it's very important. And as I said at the beginning, in like in Colombia, in our countries, there is a hygiene index, which means that there is a huge difference between the families, some families that are very wealthy and some families that live in very vulnerable conditions. And not only getting to the families that are in vulnerable conditions, but also joining them with families that are wealthy and that could give also that support, that gets a very strong community, and it really helps. It is one of the best ideas.
Yeah, I think, as you said, it's life-changing for the parents who receive this diagnosis, and that's something that we could improve probably in every country. So next questions for Dr. Agustini from Dr. Wiggett in Indonesia. I work in limited resources hospital in emergency setting. I will give the clinically CAH patient hydrocortisone immediately, but I'm unable to examine the 17-OHP level. Do you think it's the right action? Is it still necessary to check 17-OHP if the patient is getting better?
Yeah. Thank you so much for the question, Dr. Wicked. So, in my experience, if you have the patient with a CAH, and for example, this is a girl with ambiguous genitalia, hyponatremia, hyperkalemia, and also with the maybe failure to thrive or the dehydration condition, I will say that you can give them immediately if there is no possibility to check 17 OHP. But in the male patient, we have to make sure maybe we need to give them fluid first, and then we can go to history of the family, for example, and make sure about the repeated electrolyte measurement, for example, because sometimes they will come with maybe hyponatremia without hyperkalemia, or when they have a vomiting. So we have to check that first, I think, because in the male there is no genitalia ambiguity. So we have to be careful, because this patient, when you give them the medication, it will you will give for the whole life. So sometimes we need to be careful about that, because when you give the hydrocortisone immediately, the 17 OHP will decrease. So I think we have to be careful, but of course, when we saw that this is a emergency situation, we can give a hydrocortisone injection when we quite sure that this is a CAH. But we don't have also the CAH mutation analysis in Indonesia now. So maybe we can repeat it the lab or in the future, I think, because usually when they have for example, you decrease the dose, and they still will have hyperandrogenism symptom. Or if you give them the hydrocortisone, and they don't have the problem with the adrenal insufficiency or CAH, and they will develop the hypercortisolism symptom like Cushing's, striae, or maybe they really have a weight gain. Yeah. Thank you, Solen.
Thank you very much for this careful management for boys especially. So I will have next question regarding management to address to Dr. Duran as well, from Dr. Dina Fauzi. How can testicular adrenal rest tumor happen in very well controlled CAH child patient with normal ACTH and 17-OHP? And do you think a CTH is reliable for monitoring control of CH patients?
So usually TART happen in uncontrolled CAH. In my experience in Indonesia, we just our manuscript just accepted in GCEM. So we have 20 male patients with CAH, and 25% of them have TART. And the youngest patient is 4.5 years. So it's quite young, but most of So all of them that have TART, they have a late identified situation, or usually they not comply with the medication. So if they have not comply with the medication, not enough dose, or they late identified, they tend to have TART. Also, I think there is one publication. They also said that if we late identified after 1 year, so the possibility to get TART is increased. And CTH is not for monitoring control of CH patient. In the guideline of Endocrine Society, they suggest to monitor using 17-OHP and androstenedione. However, I know in our situation maybe it's difficult in low middle income country. So the most important monitoring is the growth chart. So second, usually I will use the bone age. If the growth chart, their height is still in the same curve, in the same line, that maybe our treatment is okay. And if they are like there is an increase of the growth, and the growth velocity is quite um, increased, and then we need to check our dose or or the compliance of the patient. But ICTH is not for the monitoring, and in some place I think ICTH measurement is also quite less compared to 17 OHP. So we need to have, for the good control, we need to have a slightly increase of 17 OHP, but normal androstenedione level. Okay, thank you, Salen.
So there is another question for Dr. Duran after that, I believe.
Yeah.
So how would you say that your experience in Colombia changed your practice on daily basis? Like, do you talk about the parent organization to all the patients? How does that impact your practice?
Thank you. Well, we've been doing that for 1 year. The community was born in March 2024. And over that year, mainly in Bogota, the capital where we are, it really had get spread between the patients. And the way we did it, it was by talking to the pediatric endocrinologists and the pediatricians. And as I showed in my presentation, we brought the leaders of the community to the pediatric endocrine meeting, the National Pediatric Endocrine Meeting. So all the doctors that were there could talk to the leaders and understand what they're doing and how it is very supportive, and it gets that the parents get, that the families have best adherence, more education, and have a better quality of life. So I think most of my patients are now in the community because I have been living this experience, and I think it has really worked. They understand much better. They ask questions where you really know that they are understanding, and also how they proceed when they have complications. I've had patients. I had one patient that went to the emergency room, and they were telling her it was more important to give her the stress dose, and she fought for it, and she got the stress dose, and that was for her. It was very good because she really needed the stress dose. So we also know there is a lack of knowledge between the health professionals, mostly in areas that are away from the big cities. We really have to work on that. But if the patient know what they have to do, they understand better, it really changes the experience for the doctor and for them.
Thank you very much. We still have lots of questions, but unfortunately we're running out of time. So we'll find a way maybe to answer everyone maybe on the chat directly or later. So yeah, this comes to an end for today's webinar. So on behalf of the organizing committee, I would like to extend a warmest round of gratitude and appreciation to all of our speakers for their lessons that we've learned today and their insight that they have given us. So of course, no event is complete without a photo session. So we now invite our honorable guest speakers and moderator once again to turn on your video to take a group photo. And to all of the participants, kindly turn your video on because we'll take a group pictures with all of our distinguished speaker and moderator. Just give us a few seconds to turn everyone's video on.
I'll be taking the picture. 3, 2, 1. Slide 3, 2, 1. 3, 2, 1. Thank you.
Thank you very much, Arneta. So to all of the participants, kindly fill in the feedback form as detailed on the slide and via Zoom as well on the YouTube chat. So the certificate of attendance will be shared via email upon completion of the feedback form. GPED conducts written webinars as well as other very exciting activities and opportunities for you. The first and exciting news is following the success of the first meeting, we are proud to share the second GPED annual meeting that will be conducted on November 29th, 13th, and December 6th and 7th of 2025, with the exciting theme of optimizing pediatric endocrine care in resource-limited settings, bridging access, technology management, and clinical practice. We're excited to highlight also GPED partners at Maids for Kids Community Development Grants. So that's 1,000 Australian dollars to support local CAH initiative in LMICs that Dr. Duran talked to us about. So you're more than welcome to apply if you want to improve the access to medicine. To keep you up to date, we also urge you to follow GPED on our social media platform as detailed on the slides. And once again, our warmest gratitude to all parties who've made this webinar a success. And we thank you very much for your participation. We hope to see you at our next webinar. Thank you very much to all.